Good morning, hello. Welcome to another topic. We're going to move on to post-surgery today. Again, this is a patient education series on total knee replacement. It's based upon my book, A Proactive Approach to Knee Replacement. I'm Dr. David Graybill. So we've covered a lot of preoperative things in the other videos. And now this video and the next two are going to be on the immediate post-op time frame. Again, there's a lot more detail in my book. I'm just picking some select topics that I think will be interesting for people, and hopefully this will supplement the material in the book. So moving onwards, pain management is, I think, one of the more common questions and concerns for patients. So we're going to approach that topic today. So in pain management, things have evolved dramatically over the last 35 plus years since I was training. At that time, we were doing a lot of general anesthetic, and it was a very unpleasant situation for patients because they basically were anesthetized, and the body still gets the sensation from the surgery. And a knee replacement involves not only a significant incision, but there is cutting of bone, and there's a lot of stimuli in the nervous system present. So probably the most important development in this whole process has been nerve blockade. So the number one thing here is if we can prevent the sensation from reaching the central nervous system, spinal cord, etc., we are in a much better situation than if we don't. And the question is, why would that be? What does that mean? So here we need to move on to a little discussion of the nervous system. Nervous system has a peripheral and central component. The peripheral component is basically in the body, distal or away from the spinal cord. The spinal cord and the brain are the central nervous system, and pretty much everything else is the peripheral nervous system. And you can think of the nervous system as a conduction kind of wires. The nerves work kind of like wires, and they get sensation that comes to the central nervous system, and then there are also nerve conduction away. An example of a nerve conduction away would be the ability to contract a muscle, and an example of a nervous system signal from the peripheral to the central nervous system would be temperature or pain. So if we're anesthetized, yet still significantly affecting the sensation, we get something called nervous system windup. And this is kind of like a feedback loop. If you've, I'm sure, experienced someone with a microphone near a speaker where all of a sudden it gets louder and louder, that is a feedback loop. And that's what happens if you have a significant surgery without a nerve blockade. Nerve blockade is critical to postoperative pain control. There are a small number of patients that it can't be fully accomplished, but I strongly recommend you as a patient to never refuse a spinal and or a nerve block. They are your friend. They are what's going to help you. There are some ways to do local injections into the knee for a local block. These are supplemental. The more degree of nerve block we have, the more likely it is to be successful, and the more likely your postoperative pain control will be better. So step one, block the sensation from reaching the spinal cord and the brain. Again, spinal nerve blockades commonly are called an adductor block, occasionally a femoral block, and frequently also, in addition to this, local nerve block in the surgical site. So step number two, and this has also been well established in the literature, is what we call multimodality pain management. What that means is more than one medication or type of medication is used. So you might say, for example, why use Tylenol when I can just use a narcotic? The narcotic's much stronger. What's the point of the Tylenol? Well, number one, a lot of the narcotics contain Tylenol, so there's obviously reasons for that. Number two, think of it this way. Maybe the Tylenol doesn't work a lot, but maybe it takes 10% of severe pain away, or 15. It's a small chip, but it still means you would need less narcotic than otherwise. Anti-inflammatories, a secondary medicine again. Well, they're going to work in a different site than the narcotic and the Tylenol. They're going to work more at the knee itself, and that can be very beneficial. Again, maybe it's not quite as potent as a narcotic, but it's going to lessen the amount of narcotic we need. Another type of medication might be Lyrica or Neurontin. These are affect nerve conduction. Again, they're going to be affecting the nerve itself, a little less so in the central nervous system. So at each spot that we're addressing pain means the amount of pain we need to manage with narcotics are a little less. What does that mean? That means the same amount of narcotic is going to do better. So this is a critical thing, and I typically prescribe Tylenol, a narcotic, and an anti-inflammatory in patients that had healthy kidney function. If they didn't have healthy kidney function, I chose to use maybe Neurontin in place of an anti-inflammatory, as that was not that isn't a risk on kidney function. Caution with Tylenol really is only in people that have active liver disease or cirrhosis. They need to be careful with Tylenol. Another component of this is that narcotics have significant side effects: constipation, confusion, in higher doses, respiratory suppression. And we want to use the least amount of narcotic over the shortest time period we can. A brief comment on chronic narcotic use. If people are taking chronically any significant amount of narcotics, two effects are present. One is we get a hypersensitivity. In other words, pain sensitivity, it becomes hypersensitive. And the second is something called tolerance, meaning if you take narcotics every day, you are less, you get a less effect by increasing the dose than if you're not narcotic naive. So if we're on narcotics before surgery, we want to minimize that. It's best if we're narcotic naive as far as pain management. So the next thing would be timing. Again, in the ideal situation, we have a highly effective nerve blockade, spinal, adductor canal, peripheral nerve block. And in the recovery room, if our block is very effective, we start our medications before they wear off. In some cases, we give some even before surgery, particularly when we're dealing with a fairly rapid recovery. And what happens then is that the medication builds up in your bloodstream before you experience pain. They'll be more effective. So prevention works much better than treatment. So if we wait for the pain to be bad and then try to dose medications at that point, we need a much higher dose of medications to be effective than if we have some in our bloodstream present before surgery. So I encourage people, even if they're a little reluctant about using narcotics, to use some for at least the first 36 hours or so till our nerve blocks are completely worn off. And at that point, then we know how much pain we're going to experience, and we start weaning our narcotics at that point. So that moves on to the discussion of duration. Again, narcotics are necessary for almost every patient. If we want to minimize the use, again, we start it before the blocks wear off. And roughly at 36 hours post-op, once you have experienced your maximum pain, which usually is going to occur around then, between then and occasionally out to 3 days, we should be weaning down on our narcotics at that point. We don't wean the other medicines, okay? So the Tylenol, the anti-inflammatory, and Neurontin and Lyrica, would be medicines that we use longer. Once we're off narcotics, then we start weaning those gradually. The order I would wean is narcotics are weaned first. If we're using Neurontin or Lyrica, unless we're on those chronically, I would wean those second. I would wean the anti-inflammatory third and the Tylenol last. The anti-inflammatory and the Tylenol do not develop tolerance. You can use them for a long time without losing effectiveness. So that is, I think, the most rational approach. So there are also non-medication interventions. We don't want to forget those. So we want to minimize swelling. How do we minimize swelling? Elevation, compression, and ice. And we don't overdo our activities. So we'll be talking about this in subsequent talks, but in the first few days after surgery, our focus is really on ice, elevation, range of motion, and not walking or standing for too long. We do get up frequently, but for short periods. So we need to balance our activities so that we aren't overdoing things and activating a lot of inflammation and swelling, which is counterproductive on early pain control. So that's my general approach. There are a lot more details, again, with the book. The book is available on Kindle, Amazon, Barnes & Noble, BookBaby, and Barnes & Noble. I encourage you to look at the other videos in this series. I think they'll be very helpful, and we'll move on to some other postoperative talks or topics next. Have a great day. Thanks.